radiologist here in Maryland, in Germantown and Bethesda at the Center of Cancer and Blood Disorders. And I'm on the board with Maryland DC Society of Clinical Oncology. And we've organized this meeting for lung cancer screening. It's Lung Cancer Awareness Month. And I've invited Dr. Deepak to present. She graduated from the Seth GS Medical College in Mumbai, India with honors and completed a radiology residency at King Edward Memorial Hospital, Mumbai, India. In addition, she completed internal medicine residency at Medstar Harbor Hospital and her fellowship in Pulmonary and Critical Care at University of Maryland School of Medicine. She's board certified in internal medicine, pulmonary medicine, and critical care. She's a recipient of the Jones-Stein Award for Leadership in Tobacco Prevention and Control and the 2021 and 2022 Herbert S. Waxman Award for Outstanding Medical Student Educator from the American College of Physicians. She runs a lung cancer screening program both at University of Maryland and the Baltimore Veterans Administration and is the director of the lung cancer clinic at the Baltimore Veterans Administration, where she's the site investigator for the Valor and LPOP studies. So we're looking forward to a great talk this evening. And Dr. Deepak, welcome. And again, thank you for agreeing to speak for us.
Thank you so much, Dr. Goldstein, and thanks for the invitation and thanks for inviting me to speak today. November is Lung Cancer Awareness Month, and there's nothing more important than lung cancer screening. None of us have any disclosures. As you can see, I do believe that we should breathe in clean air, not scented air of any kind, no fragrances, oil diffusers, Glade plugins. And I do believe that lung cancer screening can save lives and it should be done. So I would like to talk to you about why we are doing lung cancer screening. Why is it so important? What are the components of lung cancer screening? It's definitely more than just a low-dose CT. And how do you interpret it? Like if you get the results of lung cancer screening, what are you going to do with it? And a little bit about patient perceptions in terms of why do they have barriers to lung cancer screening, and a little bit about the provider and system barriers. So lung cancer screening became a thing because people like General John Pershing decided that tobacco is what is needed to win the war as much as bullets. So something which was a reportable condition about 100 and more years back, with only 374 cases, now has become something which kills a lot of people and is very prevalent. So in terms of lung cancer statistics, there are about 350 deaths a day. And it's a leading cause of lung cancer death in 2023. It's 2.5 times more number of people die from lung cancer compared to colorectal cancer. Is it the most common cancer in men and women? No, but it is the cancer that kills more in both men and women. And that is the most important part that we need to remember. In fact, there was an article today in Chest which said that the overall rate of lung cancer, 5-year survival of lung cancer, has improved from 22% to 25%. And I thought that was a very sad state of affairs still. So lung cancer is different in different races, right? So it is not the same. So if you look at the 5-year survival of lung cancer and you look at race and stage of diagnosis, then you do find that the Black population generally tends to have later stage of lung cancer, and their survival is not generally as good as the white population. So that is a known fact. Cigarette smoking, as you know, is the most common cause of lung cancer. And cigarette smoking is also more prevalent in people who are uninsured, enrolled in Medicaid, and people who don't have good insurance, and they are much more likely to smoke. And they have found that people with annual family incomes of less than 12,500 definitely have more incidence of lung cancer, exactly because more likely to smoke, more likely to be around people who smoke. And this is a problem because here is your socioeconomic differences coming in lung cancer. So why do we screen for lung cancer? It's a high prevalence in the high-risk population. Now the 5-year survival rate, I forgot to change it because it came as of today. It's anywhere from 18 to about now 25%, it looks like. Stage 1A survival is not bad. It's as high as 77, and I will say that it's even in some studies quoted as high as 90%. But only 15% of lung cancer is diagnosed at early stage. So again, only 15% of lung cancer is diagnosed at early stage. And this is where lung cancer screening comes in. So I have a case. It's a 51-year-old asymptomatic patient. They have no symptoms whatsoever. They have a 22-pack year history of smoking. They're smoking currently. They don't have any family history of lung cancer. And they're asking about lung cancer screening. So is this patient a good candidate for screening? And if you have access to the chat, you can say yes, no, and people can tell me later what the answers were. So let's see if we know the answers to this, right? So the two big trials that basically brought lung cancer, low-dose CT lung cancer screening to the forefront are the American trial, which was the National Lung Cancer Screening Trial, and then the Nelson trial, which was conducted in Europe. The American trial, the NLST, had ages 55 to 74. These were volunteers. These were patients with 30-pack history of smoking who are currently smoking or had quit within the past 15 years. Remember, these patients were very healthy. They were able to climb up 2 flights of stairs at least. There were 26,000 participants. And what was found was that low-dose CT showed positive results 3 times as frequently as chest x-rays, because before that, all everyone was doing was chest x-ray, and that was not good enough. And it showed a 20% relative risk reduction in mortality. The Nelson trial, on the other hand, had a younger population, 50 to 75 years of age. They took in people with 20-pack year history of smoking. They did LDCTs at baseline and then year 1, year 3, year 5 instead of annual LDCT, which the NLST did. And they found a 26% reduction in lung cancer mortality in the Nelson trial as compared to the NLST trial. So what does lung cancer screening compose of? One is you have to be eligible for lung cancer screening. Second, the most important thing is you do have to do shared decision making where you're actually discussing with your patient what it means. And then you need to know what it entails. And then the whole structured reporting of lung rads, which has to be done by the radiologist. And then you have to address tobacco health. If you do not address tobacco health, then there is really no point in putting your patient through lung cancer screening. You need to keep like a database of these patients. You have to have multidisciplinary governance and people involved in the reports. And then you have to also address the false positive rates. So USPSTF made recommendations which were recently updated in 2021, and we are now screening adults aged 50 to 80 with a 20-pack year history of smoking. This is different from previously when it was 55 to 80 or 55 to 74, depending on the society, and it was 30-pack year. Now we have changed it 50 to 80, 20-pack year history of smoking, currently smoking or within the past 15 years. So why did we do this? This was done because when they looked at studies like the old restrictive trial versus the new USPSTF guidelines, they found that the new USPSTF guidelines were able to identify more people, Hispanic people, more Black people with lung cancer at an early stage, whether it was men, and in women, it was much more pronounced that you would find a difference. There is also looking at age 50, 20-pack history of smoking, and you have not smoked for 25 years. So further expanding lung cancer screening, and that seems to capture more people who are who black population and Hispanic population better than just the white population alone. But this is still in the making. This is not going to happen anytime soon. So currently we are age 50 to 80, 20-pack history of smoking, quit within the past 15 years. Okay, so what is shared decision making? It involves you discussing with the patient what is lung cancer screening. That means you're signing up for lung LDCT now, you're signing up for tobacco health now, you're signing up for follow-up with CTs based on your lung cancer screening findings. So if you find a nodule that requires a CT, not in 12 months, but in 6 months, you're signing up for all of that. So it's about discussion with the patient about it, discussion with the patient about what is a low dose CT. So it's an effective dose of 1.5 millisievert. But what does that mean to me? It means nothing to me. Natural background radiation in the US is 3 millisieverts. So you can tell your patient that it's definitely less than the natural background radiation. So that will make much more sense to them, because everyone gets afraid of radiation, but that does make more sense to them. And you tell them that they are going to get CAT scans every year, either till they turn 80, or if they've stopped smoking within the past 15 years, whichever comes earlier. Now, what are other alternates? I see this happening all the time. So if your patient is due for a lung cancer screening CT now, but they have come into the ER, they're having chest pain, and they undergo a CTPE protocol, that is okay for lung cancer screening. You don't please order another LDCT on this patient. If your patient has a CTA for aortic aneurysm, that can also constitute as an alternate for LDCT. A CT chest for something else, fibrotic lung disease, HRCT for fibrotic lung disease, any kind of inspiratory and expiratory CT chest, which is done for some other lung condition, all those can take the place of LDCT. I'm not saying order those every year, but if your patients clinically require any of these, they can serve as placeholders for LDCT unless parts of the lung are not visualized. So what do you do with what is this lung RADS that everyone talks about? Lung RADS had a revision in 2022. It's very extensive and detailed. I'll try to make it as simple for you as possible. So 0 is, say, part of the lung is not visualized. They cut off the top part of the lung, or they did not go all the way below the diaphragm, then that is considered as a lung RAD 0. Or for example, you do an LDCT, you don't know that the patient has fluid overload. They have bilateral effusions, which is covering the entire lung. That becomes a lung RAD 0. Lung RAD 1 is when there is no nodule at all. It's a clean CT, no nodules, or those nodules are completely calcified. So calcified granulomas feature as lung RADS 1. That means they are not concerning, they do not need follow-up, or if you see fat containing structures. Lung RADS 2 are those nodules which are not worrisome and they require a CT in 12 months. The prevalence of lung RADS 2 is pretty high, it's 45%. The risk of malignancy is less than 5%. So what constitutes a lung RADS 2 nodule? So lung RADS 1 is something like this. It's a CAT scan and you have no nodules. You just have vessels. You have your bronchi, and you may have some early fibrotic changes, but no nodules is lung RADS 1. Lung RADS 2 can either be a small solid nodule less than 6 millimeter, or it can be bigger, what we call as ground glass. That means you see through it. You're able to completely see through that nodule. That's what is called as ground glass. And that nodule can be up to 30 millimeters. So up to 3 centimeter pure ground glass nodules are still considered as lung rats too, because these are very, very slowly growing pre-invasive uh, features, and hence they are considered as lung rats too. So lung rats too are small nodules if they are solid, or they are nodules up to 3 centimeters when they are pure ground glass. Now, lung rats 3 is a nodule. Now, it's not an annual LDCT. This is a nodule you need to follow up in 6 months. So, what constitutes this nodule? This is a nodule which is more than 6 millimeters but less than 8 millimeters. That means this nodule is something which needs follow up, but it's not big enough for you to biopsy. So if you think about a 6 millimeter nodule, that's slightly bigger than the tip of a pencil with an eraser, because the pencil with the eraser top is about 5 millimeter. So 6 millimeter is slightly bigger than that. So that's not something you can poke a needle and biopsy in. So that's a solid nodule, which is 6 to 8 millimeter, or it is a ground glass nodule which has become solid. So let's go over what would constitute as lung rats 3. So this kind of nodule, it's 7 millimeter. It's starting to look ugly. It's not something which is small. It's looking ugly. That would constitute a lung rats 3. And this is a nodule. If you are busy in private practice and you really don't have time to follow this is a nodule you can send to your pulmonologist. Lung rats 4 is a nodule you have to sit up and think about it. I think about lung rats also as asthma zones, right? Lung rats 0 and 1 is like asthma zone green. Lung rats 0, 1, and 2. Lung rats 3 is like asthma zone yellow. And lung rats 4 is asthma zone red. That means you need to act on it immediately. You don't have time. So what is lung rats 4? Lung rats 4 are those nodules which need further testing, more diagnostics, biopsy, but whatever it is, they need action now, not action later. Sometimes in lung rats 4, depending on the size of the nodules, you may end up doing a CT in 3 months, but this has to be a decision made by people who follow these nodules regularly. So lung rats 4 can be something like this, which is an air-filled space which decided to now fill up, and that can become a lung rats 4. This nodule, which was sitting, which was 10 millimeter, already bad, becomes like really nasty looking and 18 millimeters, and that becomes a lung rats 4B or something which needs action immediately. Anything you ever see which is inside the airway, inside the main airways, always needs action immediately. That's a lung rats 4. Then in addition to all of this, you're going to start seeing reports which say significant results. Significant results means that it's not related to lung cancer, but there are other things going on in this patient. And what they mean for significant results is not things like aortic aneurysms or thyroid nodules or emphysema or fibrotic lung disease. These are other things like, oh, your patient has pneumonia. They have consolidations. They have areas of diffuse ground glass. They have mucus in your trachea or bronchi, or they have fluid overload, or they have pleural effusions, or other things which are containing fluid containing cysts, or they have tree in bud opacities, which is indicative of an infection and small airways disease. These are all the language you're going to see from your friendly radiologist with this new significant modifier. So why is size important? Because as the size increases for a solid nodule, this is only true for a solid nodule, size increases, risk of malignancy increases. A ground glass nodule, as the density increases, that means as the ground glass nodule gets more and more solid, the risk of cancer increases. So for ground glass nodules, it's the density. For solid nodules, the size matters. So again, as I said, pulmonary referral, lung rats 3 and above. If you want clarification of significant findings, send them to your friendly pulmonologist. Whatever you do, don't say things to your patients like you can stop smoking now or wait until your cremation. You need to do more than that. So lung cancer screening is part and parcel of it is tobacco treatment. It is very important and crucial. So if you look at the effect of stopping smoking, so patients with, if you look at 5-year survival rate of patients 65 years and older with early stage of lung cancer who stop smoking, it's 70%. But those who continue smoking is 33%. A big difference, big difference. The combination of smoking abstinence and lung cancer screening results in 38% reduction in lung cancer mortality as opposed to that 20% reduction I told you earlier. They also found that lung cancer screening itself does not influence smoking behavior. It really doesn't do it. Sometimes positive results associates with smoking abstinence. 77% of the NLST participants continued to smoke even after 3 rounds of screening. And in the Nelson trial, 41% of them said they had no intention to quit smoking. So again, it is not just important that you enroll them in lung cancer screening. It is much more important that you educate them about tobacco treatment and you start doing tobacco treatment. So what does that mean? So if you look at the NLST participants, the current smokers at the time of enrollment had a 2-fold increase in lung cancer mortality, whereas the former smokers in the LDCT arm of the NLST had a 20% mortality reduction. And the former smokers who were in the chest radiography arm, who remained abstinent for 7 years, also had a 20% reduction in mortality. So what does that tell you? It tells you that if you stop smoking, you can get the same mortality reduction or an additive mortality reduction compared to just doing LDCT. And when I say stop smoking, it does not mean the 5 A's. I mean treating tobacco as a disease, as a chronic disease. It's a completely different talk. I'm happy to talk about tobacco anytime. You have to treat it like a chronic disease. You need to do counseling, but you have to give your patients treatment. There is nothing like when you're ready to stop smoking, I'm going to give you intervention. That's not how it works. That myth has been busted. You have to give people treatment along with counseling and behavioral modifications, and this is an integral part of lung cancer screening. Sorry, you have to have some kind of database if you are a person who is doing a lot of lung cancer screening, and you have to have all the elements written in that database. If you have nodules that you don't know what is going on, it is best to have multiple people involved in it. When I'm talking about it, I'm talking about things like thoracic tumor board and many people looking at nodules and coming up with a collective plan on how to take care of it. Now, false positive rates, especially in the NLST, was 24% at baseline and 27 and 16% for the 2 subsequent rounds. Now, remember in the NLST trial, they were using 4 millimeter nodules as the base. So since your lung rats criteria have improved, it has decreased the false positive rates to now 6 to 13%. And of course, your false positive rates are dependent on the radiologist who is actually reading it. Because if your radiologist is not someone who's reading a lot of LDCTs, there is going to be a lot more false positive. So it's very, very important that it is something that it is read by radiologists, and that's why that ACR certification and the radiologist reading it have to be good. Otherwise, it's only as good as the people who read it. So, why is it that lung cancer has such a dismal rate, right? Why is it that only 6%, and I think in Maryland it's maybe, yeah, it is still 6% even in the state of Maryland, and maybe in certain places it's about 11%. Why is it so bad, right? Why is it so bad? If you look at it in academic centers, it's about 28 to 38%. But look at breast and colorectal cancer, that is 76 to 81%, and about 59 to 65%. So, why is it that lung cancer screening rates are so bad? There are many, many barriers. There are patient barriers, there are provider barriers, and there are system barriers. So let's look at what are the patient's barriers, or what does a patient feel. So when you are asking the patient and when they are looking at appropriate follow-up, right? So it is not the first LDCT that matters. It is actually the second, third, and the follow-up LDCTs after that which matter, because more than half of all those screen detected cancers in both the NLST and the Nelson trial were detected on the subsequent rounds of screening and not on that first round of screening. So that's very important to know. So it's not one and done. It has to be done every year, or however the interval is, depending on what you find on lung rats. So patients who have undergone the lung cancer screening say, oh, it's pretty easy. We can do it. It was not a hardship. Everything is easy. It's not invasive. It's not embarrassing. It's a pretty decent experience. You're high risk. We think we should do it. If my doctor says I need to get it done, I think we need to do it, right? And, I think based on my history of smoking, yeah, I should get it done. So these are patients who actually are more adherent to lung cancer screening, right? And they absolutely do it. But there are other things, right? The provider recommendation is the huge motivator for any patient to get lung cancer screening. It's a key facilitator in most patients, okay? So they say that if my healthcare provider recommends, I'll do it, right? I didn't know it could be done until primary care suggested it. If my doctor thinks I need it, I'll do it, right? Because otherwise, I don't think anything is wrong with me. So I don't think I should get screened, right? Like, I'm breathing a lot of stuff. So, and I'm smoking cigarettes. So I think I should get it. And the higher risk of cancer, I think I should get it. So it all depends on what the provider tells the patient and how they educate the patient. And you can get it from the patient codes here. Now, unfortunately, right, even though the patients understand, as you can see the first two codes, that it is very important to get lung cancer screening, sometimes they don't understand the full import of it. And this is why you have to educate your patients that lung cancer screening, when it presents with symptoms, you are on stage 3 or 4. You're not in your early stages. So patients say, if I had lung cancer, I'll have a symptom, I'll know it, right? Like smoking person like me, I don't think like screening, right? Like, I mean, I don't know if it's going to really have an effect. Like, why don't I have a cough? Why don't I have something that tells me that there is a problem, right? So patients do not necessarily understand the concept of asymptomatic screening for lung cancer. They seem to understand it for breast cancer. They seem to understand it for colonoscopy. They do not seem to understand it for lung cancer for some reason. And I believe it's mainly because lung cancer occurs in smokers. Smokers already feel the stigma of the entire lung cancer thing, and they feel that they are victimized in many ways, and they feel that this is one more thing which is going to open them to ridicule or other things. There is also concerns of cost, insurance, ability to get there, transportation, right? Like if someone can just get it done very easily and the logistics are easy, that's fine. But then, you know, if the insurance is not going to pay for it, they cannot get it, right? And that is why it's very important as providers to make sure that you have your shared decision making, you have everything done so that the insurance pays for their lung cancer screening. And then other health conditions, right? Like, I mean, I don't have the time for it right now. I'm too sick. I have this going on with my breast cancer. I need that taken care of. I don't think this is important. I think I have a cough or I have knee pain. I'm going to put this off for now. So they do not prioritize lung cancer screening the same way as it should be prioritized. But again, this is where the restructuring of the thinking can easily happen with provider interaction. And patients also have variable preferences in terms of how are they going to receive the lung cancer screening results. For example, in the VA, for all lung grads 0, 1, and 2, we just send them a letter and tell them that that's what they have, and they get a phone call. For lung grads 3, they get a phone call and they're given an optional ability to come in for a visit. And for lung rats 4, of course, they're scheduled in lung mass clinic because it's a diagnostic clinic. In the university side, what we do is we get all the people in, they come in for televisits. If it's lung rats 3 or 4, they come in for in-person visits so that we can have discussions with them. We can show them their CAT scans. We can explain how important it is for them to follow up, right? So I think that it has to be about patient understanding. The patient has to understand what you're trying to tell them. So it is not just about getting the CAT scan, it's about discussing about the results, and it's about making them understand what are the next steps or what to expect next. And then they need reminders. People need reminders. We need reminders. As we get older, we are putting reminders in multiple places and still we forget things. So patients definitely need reminders and they need some kind of facilitators for annual screening. And they really like someone like a nurse navigator whose job it is to remind them, you're due for a CT now, you need to get the CT, call radiology, make sure you schedule the appointment. Or things like, okay, you know, we have this spot in the lung, we need to get a PET CT now, you need to come to clinic now, these are the steps, here are your scheduled appointments. They really feel that having a navigator really helps in this process. And then the whole, as I told you, the misconceptions about asymptomatic screening, right? My doctor told me that the information is not always accurate in lung cancer screening, so I don't think I should do it. Or like, if that is why they don't go ahead and do it, because they say, okay, nothing's wrong with your lungs, you don't need, like, everything is fine, so they say, okay, we don't need to do anything anymore. Or they tell them, well, lung cancer screening is not going to tell you everything about your lungs, so they say, okay, then what is the point of doing it, right? Whereas patients who are adherent usually have reviewed their results, they have discussions with their providers, and they have more teeth in the game, if you will. The other thing is access, right? So this was a very neat study which looked at ACR lung cancer screening facilities and the distance, right? So if you look at some places, you can see that how few Look at Wyoming and see how few ACR lung rats facilities are there. And then they also looked at lung cancer screening, like Wyoming has one facility. Like naturally, we are in the Northeast, so we are lucky that we have a whole bunch of facilities. So if we look at the state of Maryland, we are not doing too bad in terms of access to a lung cancer screening facility and a lung cancer screening program. If you delve it down further into Maryland and you look at where there is more smoking, and of course, in the state of Maryland, most of the smoking happens in areas which are deprived or inner city Baltimore and other places, but you still have access to lung cancer screening. So luckily for us in the state of Maryland, our access to lung cancer screening is still pretty good, irrespective of our mortality rates and irrespective of the area deprivation index. Rural areas definitely have more incidence of lung cancer screening. And the biggest thing is higher rate of tobacco use, lower education, and of course, the access to care, right? And the access to care, the health literacy that's involved is definitely less. Do we have a Susan Komen walk for lung cancer screening? Absolutely not. Why do we not have it? Because lung cancer has always been associated with smokers. There are no people who are going there and saying, this is lung cancer screening day. Let us have a walk for lung cancer screening. There's nothing positive being said about smoking and lung cancer. And because of that, we do not have that kind of engagement. Now, what is the problem in terms of providers? You will not believe this study, which was done at UNC, where they looked at lung cancer screening and the barriers to lung cancer screening in terms of providers. Okay, so this was a study done in 2015. They surveyed about 100 primary care physicians, 86 attendings, family medicine and internal medicine, and they focused on what do they think are the barriers in lung cancer screening. First barrier was the cost to the patient. And then they said, I'm not sure if it's really beneficial for the patients. Then they said, I think that the recommendations are a little bit inconsistent. I don't think that the screening is really cost effective. I I don't really know on what the specialists are saying about lung cancer screening, and I don't agree with what they say. They 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 feel that they have good enough knowledge to explain pros and cons, but at the same time, there is not enough time to discuss about these pros and cons and explain to the patients on why lung cancer screening is so important. This was unfortunately one of the only studies done. So, but it tells you, it gives you a general idea on how there is so much of mistrust about lung cancer screening still amongst providers. And this definitely is one of the biggest barriers in lung cancer screening uptake. There definitely are system barriers. This was a study done in Kaiser Permanente and looking at all lung cancer screening and looking at system barriers. And definitely you can see that, look at the follow-up rates, even in places where there is a good established lung cancer screening program, it is not very good at all, unless you get to things like lung rats 3, where people are really worried about it and you get follow up. But if you look at lung rats through 2 and negative lung rats, the rates of follow up are not excellent. So when you look at system barriers, there are certain key things, right? Who is responsible for it? Who is really responsible for lung cancer screening? Who is it that's responsible? Is it the primary care provider? Is it going to be the specialist? Who is responsible? Who is doing it? Who's ordering it? who's following it. And then the coordination between everyone, right? Between primary care, the pulmonologist, nurse navigators, if there are, who is negotiating all of these things. And I'm going to give you a couple of examples on both sides, and which will help you understand it a little bit better. And then you have to train clinicians, right? You have to train clinicians who are taking care of patients in lung cancer screening. And you also have to train people like MAs, because MAs, right? For example, we have this, I don't know how many $1 million epic rollout for lung cancer screening, which everyone said is going to be the best thing that is going to happen at University of Maryland. We're going to have a nice lung cancer screening database. Except we realize that we do not get alerts for lung cancer screening as the best practice advisory, because the MAs routinely go in and change the tobacco history, and they do not take adequate tobacco history, or they write things like stop smoking, and that takes away the ability of the system to be able to identify patients who are eligible for lung cancer screening. So you don't get the best practice advisory activated. So if it's not activated, you are not prompted to order it. So something as simple as that is very, very important when we are thinking about system barriers. Let me talk to you a little bit about clarifying roles and responsibilities. Initially, when we were doing lung cancer screening in the VA, anyone was ordering lung cancer screening. We were allowing primary care to order it. We were ordering it in lung mass clinic, and we found that it was very scattered. It was not being read correctly. It was not being ordered as low dose CT, and it was a complete mess. So we then decided, we in the lung mass and lung cancer screening team are going to take full responsibility for it. So we created a lung cancer screening consult. We said, all lung cancer screening, just place a consult. We'll do the shared decision making. We will document everything. We will order the CT. We will do the necessary things so that it goes into the automated database and it gets followed. That automatically improved the system that was there before, where patients were getting lost, patients were not getting LDCTs, patients were not getting read as LDCTs. All that improved. On the university side, till today, we are struggling with the fact that so many people order the LDCT, it is not getting captured into the LDCT database. There are nodules which are not getting followed up, and there is no one who is owning up to that person's LDCT. Because if you are a busy primary care provider and you have so many of these alerts coming to you every day, you are going to look at it quickly. You're going to maybe shoot a email or tell your whoever it is, your clinic person or someone, call so and so and tell them to come in and get a CT now. But how are you going to keep track of the fact that that person now needs a CT and they've not got it done now 3 months hence, 6 months hence, 12 months hence? You are not going to have the time to do it. So it is very important to have automated systems which give you reminders. It's very important to have like a centralized system of lung cancer screening. So that is some of these barriers that I'm talking about. And then the same thing about automating EHR tools. It's great to have automated EHR tools. You definitely need it to reduce our clinical burden. You need something to prompt you, but you also have to remember that you have to do it in the correct way, and you have to create some kind of metrics to follow it. So institutions which do lung cancer screening definitely need to be following the metrics very well, and the VA is doing a very good job of it, unlike the civilian sector, I must say. And then you have to also think about it, right? Like some people have proposed, why don't you give financial or non-financial incentives for people who, complete their follow-up LDCTs, provide a convenient location, increase patients' knowledge, tell them what are the tests that are involved, kind of give them reminders for their appointments and follow-ups. These are things that are going to definitely improve your adherence. So in my last slide, I want to summarize the fact that LDCTs are done, that is low dose CTs are done for lung cancer screening for people aged 50 to 80 who have 20-pack history of smoking, cigarettes only, not cigars, not cigarillos, not water pipe hookahs, not vaping, cigarettes only. The radiation dose for low dose CT is lesser than background radiation. Lung cancer, lung rats 3 and 4, positive results do need follow-up. Remember, lung rats 3 is like your yellow zone for asthma. That means it needs action pretty promptly, but not immediately. Lung rats 4 is immediate. Now I need to stop whatever else I'm doing and focus on this. Shared decision making is crucial and documentation of this is crucial to lung cancer screening. False positive results can definitely are not as bad now, and they can definitely be mitigated by good reading by experienced radiologists. The barriers, of course, exist to lung cancer screening, right? But it is your job to encourage everyone to get lung cancer screening. And there's still a shout out to Maryland Department of Health and the Maryland Lung Cancer Screening Collaborative. If you are a primary care physician in the state of Maryland, we are looking for primary care providers. So please do email Brian Mattingly right there. And I think that's all I have and questions. So I'm going to stop this, stop sharing, or I can still be sharing, but questions, concerns?
Hi, my name is Kim Bathurst. I'm from RadNet in Maryland, and I oversee our tracking departments. And one of the things that I wanted to share that I didn't see in your presentation is some really good, some legislation was passed in Maryland that goes into effect early next year, in that if patients have a positive lung screening and warrant additional imaging, that Maryland-based insurance companies will be required to pay for those procedures. So that's some really exciting legislation. It was combined with some breast imaging as well. So it's really exciting news for patients in our underserved communities and patients who have there are financial barriers and hurdles to access to this additional care. So that's great news. I just wanted to add that comment.
Yeah, well, we definitely we made a lot of noise about it in the State Department, so we got them to start thinking about it last year. So I'm very aware of that, but I did not know that they're going to start paying. But having said that, unfortunately, the Medicaid population, they still are not paying for it. And I'm waiting for this legislation to not only come into effect, but really be enacted and enforced. Because if you look at our population, me and Panagis from Hopkins, every time in our lung cancer screening collaborative, keep talking about the fact that insurance is one of the biggest factors for our patients not getting lung cancer screening. And the other factor is patients in the state of Maryland, especially, right? If they end up going to some other place and getting their lung cancer screening and they don't get it at your parent institution, naturally insurance is not going to pay for it because they see that someone's got an LDCT and you don't see it, right? So in fact, we're trying to work with CRISP. If you're in Maryland, CRISP, which is a exchange program for all health information. We are trying to work with CRISP to see if there is any way we can get notified if our patient gets a CT somewhere else, a CT that can qualify for lung cancer screening. And it's great if they have positive results and they're going to pay for it, but I would love for it to be paid even if it's negative results and consistently paid. And that doesn't happen often. So, but thank you for bringing that up.
My pleasure. Thank you.
Dr. Deepak, you have there is a question in the chat. What are your suggestions on how to improve access to veterans?
So actually, veterans have very good access. So if you're in the state of Maryland, I will tell you that in the Baltimore VAMC, we have a lung cancer screening program, and that lung cancer screening is available not only in Baltimore, it's available in Perry Point also to our veterans. It is a centralized program. They don't have to come in for the shared decision making. They only have to come in for the LDCT. And it's a very established and well program. And I'll tell you, DC also has an excellent lung cancer screening program. Martinsburg, West Virginia does not have one. And Clarksburg does not have one as yet. But the VA is definitely at the forefront of lung cancer screening compared to the civilian structures, because the VA has enacted the lung cancer precision oncology program and has put millions of dollars into it and has established 16 hubs with multiple spoke VAs so as to improve lung cancer screening all across the nation.
And then there's a follow-up. What about return for a second annual exam? As you said, the return is most important.
Yeah, so that's the problem, right? So when we say you're seeing the patient for lung cancer screening, you've talked to them about their lung cancer screening results. It is important at that time for you, if you're running the lung cancer screening program, to tell them you are going to get another phone call 12 months from now and you need to get an LDCT. But I will also say that it's important for every single provider who then interacts with that patient to re-emphasize with them, it's time for that CT. It's time for that CT. Did you call radiology? Did you make that appointment? Can you please make that appointment? Can you prioritize this? So that is what is important. It's just like having an Alexa in your home. You have to be your patient's Alexa, continuously reminding them that they have to do it. So it's up to the facility that did the LCS to follow up with the patient, not the VA. No, if you're talking about the VA lung cancer screening program, we are trying in the VA to have all lung cancer screening done inside the VA and not outside. If a veteran goes outside the VA to do lung cancer screening, then it's up to the primary care provider who sent the veteran to lung cancer screening outside, because we are not able to follow those patients because of the simple fact that we don't have access to all those images. We don't know how the person has read those images, and we cannot keep track. Like in the VA lung cancer screening program, we have about 6,000 veterans already enrolled from 2021 to now. So it's a huge number of patients in the veteran side. So if a person goes outside, we won't know about it. And that's true for any facility which does it, right? If you are at Joe Schmo facility and you're seeing a patient and you're ordering the LDCT, if your patient doesn't get LDCT done at your facility, gets it done somewhere else in a facility that doesn't talk to your facility, then we are not going to be able to have access to it. Like I have access to advanced radiology. We have access to CRISP in Maryland, but we don't have access to many other things. And I don't know if I have to look at CRISP, right? If I don't know if your patient has had the screening, right? So there has to be, this is where the communication is very important. And if there is a centralized system of doing lung cancer screening, and if the primary care knows that the veteran's going outside that centralized system, it's important for the primary care to kind of have a conversation and decide who's following that patient, if that makes sense.
Dr. Deepak, another question for you concerning veterans. the veterans that you talk about, I'm assuming, are qualified because of their PAC years and smoking history. But as we know that there are veterans who have environmental exposures by whatever, campaigns that they have been in and so forth, as well as a separate group of people of firefighters and exposure. So what is your stance of qualifying those individuals, if they're not smokers, of lung screening, and what is your thought of screening in those groups of folks?
So I will tell you to look at my Seminars of Oncology paper, which I looked at, which talks about lung cancer screening and military exposure. So it's definitely something that we are looking at in the veterans. There isn't enough convincing data as yet to qualify them. I brought this up in the American College of Physicians national meeting last year to the USPSTF group to ask them why they haven't included other exposures, because not only in the veterans and asbestos workers, coal miners, everyone else where the risk is higher. And they said that it's because of the uptake of lung cancer is so bad, even in those people who qualify, that the opening up the qualification to other exposures at this time is not warranted. In terms of the military exposures, the data is not yet there. That there is definite work going on. I am very interested in this and I'm working on it. There is not, the problem is it's not just the exposure, right? It's also about quantifying an exposure. Yes, you went to Vietnam, you were exposed to Agent Orange, but were you really exposed? Were you up in the air? If you were in the air, you were not really exposed to Agent Orange. Only if you were on the ground, you were exposed to Agent Orange. And if so, how much of exposure was there? So there is a lot of quantification of these exposures. Where is it occupational exposure, like people who work with chromium, right? Do nickel. These are high risk for lung cancer. That doesn't have to be just in the veterans, right? Asbestos, high risk for lung cancer, right? But it's all about quantifying this exposures and going from there. The asbestos group has a very good lung cancer screening program already present, and that all goes through occupational health, but that is not covered under any of the regular insurances, because right now we need data, right? Data is what drives all this. So the data for veterans specifically and firefighters specifically is not yet there. Particulate matter definitely increases risk for lung cancer, but the data is still not there to say that we need to do it. And I would say even cigars, right? Did y'all know that one cigar is like a pack and a half of cigarettes? That's a lot of cigarettes that people smoke when they smoke cigars, right? So why is that not qualifying? There's more and more data saying that vape devices increase a risk of cancer. So there is so much more that we have to do. But the problem is that the uptake is so bad, even for the existing data-driven screening, that widening the screening, I don't think is going to be what is needed. I think what is needed is we just need to get everyone to lung cancer screening. We just need to get the people who are eligible to screening, through screening, keep them in screening. Sorry, I'm pretty passionate about it. I apologize if I come across as ultra passionate.
No, not at all. Thank you so much for your response. Appreciate it.
I thought I was passionate about it. No, it's great. It's great. I've been trying for a couple of years now to do exactly what you're doing and get the word out. And I think it's really excellent. Your presentation and exactly what you're telling everyone to do is exactly what I've been telling people to do, and trying to get the word out is really important. I've actually seen here in Montgomery County public buses on the whole sidewall of the bus. It talks about lung cancer screening on there, and just different ways of getting the word out, basically.
So one of the interesting things I had picked up on one of the conferences were talking about the fact that why do people not like lung cancer screening? Um, because when you do breast cancer screening, right, it's called mammography, right? They don't usually use the word breast cancer screening. Even though we say colorectal cancer screening, for the patient, they hear the word colonoscopy, right? But for lung cancer screening, we keep using the word lung cancer screening. So, in fact, for the VA, when we did Lung Cancer Awareness Week, I called it as lung health screening because it's lung preventive health, right? Which includes both lung cancer and tobacco health. So maybe our wording is also something that we need to work on and talk about lung health screening and say that lung preventive health screening, right? Then that does not have those negative connotations as using the word lung cancer.
Yeah, I think that's hugely important because some of the studies
Yes.
that I've been collecting in the last couple of years on lung cancer screening have indicated that a large percentage of patients who went for lung cancer screening and didn't have any cancer finding had a new diagnosis of basically emphysema, right? And the
Yeah,
patient didn't even know they had it. So to
yeah,
your
yeah.
point, it's more than just lung cancer screening that you're getting out of that, right?
Yeah, it's exactly that. And we just presented an abstract at American Thoracic Society where we found that in the veteran population, especially, we found hepatic steatosis and osteopenia higher rates than our university population. But you can make out all of that all on an LDCT, right? So there's so much more to it than just lung cancer. So I wish that we would change it to lung health screening or lung preventive health screening so that people would not, balk at the word cancer. And then what other incidental finding we commonly see? So other than emphysema, aortic aneurysms, coronary artery calcification, thyroid nodules, we see hepatic steatosis, we see osteopenia, um, and then we sometimes we see quite a bit in the VA, especially fibrotic lung disease, asbestos related pleural plaques, depending on the age. Like the older people, you see asbestos related pleural plaques. Um, Rarely we see adrenal nodules. We see commonly kidney renal cysts, sometimes renal nodule cysts, which need further intervention. We also see anterior mediastinal cysts or nodules. Yes, a lot of it. Sorry. I can go on and on.
You are so knowledgeable on this subject. It's amazing and incredible presentation. Good
Yeah, I'm a
information.
radiologist by training. So, LDCT is all in my area of, like, I love it. I love what I do, and it's multiple. And I'm a pulmonologist by training. So I look at it in so many different angles, and I feel that this is like a missed opportunity. And I feel that, like, for example, we honestly should not use the word smokers, right? We should say patients who smoke cigarettes, right? Like, there's so much more we can do to this, and so much more positive connotation we can give this. And we really need someone like Susan Cohen to do lung cancer screening, someone like energetic and bright and do a run for lung cancer screening. So
Maybe we
anyway,
should call it
I'll stop
pulmogram.
talking.
We have a mammogram and a pulmogram.
A pulmogram.
Yeah,
That
we
sounds
can
good.
call it a pulmogram.
Yeah.
Yes, that's not a bad idea at all.
Anything to encourage people in a positive way.
In a positive way, yeah. And we
Yeah.
often also, when I see a patient for lung cancer screening, I often also offer them PFTs if I feel that it's warranted. We offer PFTs too. So we try to do it as a whole package, like, not just screening, but really like a pulmonary preventive health. I see I'm talking beyond time, so I apologize.
Dr. Goldstein, did you want me to talk about, let everybody know about the continuing medical education credit?
Go for it.
There is one credit available for Dr. Deepak's talk. Was acquired through the MedChi, the Medical Society, in Maryland for Maryland and DC. I think they're both. It's for both Maryland and DC. But at any rate, they do require an evaluation. They do not have a direct link to their website for you to obtain your credit, your CME credit. So they're asking that I will send you the evaluation form if you need the credit, and you'll need to send that back to me. They will require a summary of the evaluations. So it may take, what I thought is just, give a couple of weeks for you guys to get your evaluations back in, and then I will take that information and I will send it to you, MedChi, and then they will be the ones to issue your CME certificate and send that to you. So I'll get that out to you right away. And Dr. Deepak has graciously agreed to share her slides. I'll send that as a PDF to you with the follow-up email for the CME credit, information about the CME credit. So
this is a great talk. So thank you for, again, agreeing to speak for us. I really hope that this was one of my long-term goals anyways, especially starting with Medesco, which was to have an annual November lung cancer, eventually symposium, but definitely include lung cancer screening every year in November as part of this. And that'd be great if we can do that next year as well. Tell for the guests here tonight, please spread the information, and hope you enjoyed the program. And Dr. Deepak, if there's anything you want to work on with me outside of this venue to work on lung cancer screening, please let me know.
Will do.
Happy to work with you on some of this stuff.
Yeah. Take care. Thank you so much.